Good morning and evening, wherever you are in the world, and welcome to the Bonnie J. Addario Lung Cancer Living Room and Patient Educational Series. I'm Bonnie, and thank you for joining us. From our living room to yours. We are all living with lung cancer, and our goal is to bring hope into your home. Empowered patients live longer, and our message is simple. We want you to live.
Hi and welcome to our first live stream. So I'm not sure how many people are signed on right now. As I told everybody, this is a soft launch. So we want to get feedback from everybody here in the room and the people that are online to tell us how they feel about what's going on today. We're really, really excited to be able to bring what we're able to bring to you all here in our living room to everyone's living room at home. So it's very cool. Thanks, Peter. So a couple of things I wanted to start off talking about tonight really quick, mostly for purposes of respect for other people when they're talking, is if we could keep the sidebars to a minimum. We will get to everyone's questions, I promise you. If we have to go over, we will. But it's hard enough to hear in here. Although, per request of several people, we do have microphones. You'll see them sitting on the tables in front of you that everybody can share, so that the people on the other side of the room and the people sitting in their living rooms at home can hear what you guys have to say. The sign-in sheet is here. I'll pass it this way. I will reiterate, if I have your phone and email, you don't need to write it down again. If you are still not receiving emails from me, it's either because you haven't given it to me or I've written it down wrong. So if you have not received an email from me, please write it down again. Also, if you are new to the living room or if you have never signed a release form saying that it's okay for us to air you on TV, please do so.
Or if you don't want your picture on the side of a bus.
Yeah.
That could happen too.
Yeah. If you absolutely do not want your face seen, we have a place in the back that you can sit. So I think I've told most of you that before. I made the mistake last month of not introducing a couple of BJA people who were in the room. I think most of you know Scott Santarella. He's the CEO of the Bonnie J. Addario Lung Cancer Foundation. Came on board about a little over a year ago, and it has been a wonderful addition. Andrea Parks, who's back here in the black, grabbing the bottle of wine secretly. For all of you at home who don't know, please, if you feel like having a glass of wine, open up a bottle, because several people are having it here.
We found that lung cancer and wine go together nicely.
Yes. So Andre's in charge of special events here at the foundation. Jennifer Hughes, who's sitting way in the back, she just came on board last month, and she's our new affiliate and independent fundraiser person. So we welcome Jen.
We have people all over the U.S. doing independent fundraisers for us, so that's what Jen's doing.
It's fantastic. Danny Gasparini, who's also in the back. I always mess up her title, but she's
Pain in the
EVP of Strategic Alliances. And she's been on board since just after the beginning of the year. So we're really happy to have her too. And then Stephen Young, who is all the way out here from Connecticut. Stephen is with Alchemy, the Addario Lung Cancer Medical Foundation, which most of you are familiar with. And he's going to give a little what's happening with Alchemy at the end of tonight's meeting. So with that, I'm going to pass it over to my beautiful mother so she can tell her story to those of you who may not know it, and then we will start from there.
Okay, but sure, I'd just like to ask everybody, how do you like the floors?
Oh, very good.
We've been working really hard trying to make this room your home away from home. And I hope we're succeeding. My story is I'm going to get a neck lift. That's all there is to it after seeing myself on TV. Plastic surgery, let's go. my story is, short, 8-year survivor. So, talk about bringing hope home. Something for all of you to aspire to. It's possible. Instead of telling you my story, because I'm sure you all know it, and if not, get on the website and you can read it. It's no big deal. But I want to just tell you one thing that I'm so excited about, and it's molecular testing and new buzzword, personalized oncology. You hear personalized medicine all the time, but personalized oncology. And we were just talking to one of our favorite docs the other day at University of Colorado. His name is Ross Camage. He'll be in here doing one of our living rooms. He's amazing, absolutely amazing. He called me so excited and he said, Bonnie, you're not gonna believe this. He just wrote a paper. He had a patient that was ALK positive, had the ALK biomarker, and became resistant to crizotinib because that's what happens. These therapies, you get resistant and you go on another one. And they rebiopsied this patient, and all of a sudden they had the EGFR mutation. So now they're on Tarceva and still kicking ass. And this is such good news for everybody in the room because there are new things happening every day. And we've also learned that you become resistant to a drug, and then you take another drug, and then at some point in time, you can actually circle back because the resistance has gone away and the drug starts working again. So, there's good news on the front out there, and Stephen will address a little bit of this later on in the meeting about what Alchemy is doing with some clinical trials, and happy to see new faces here and happy to see all of our old faces here, and our goal is that you all leave tonight with hope. And how happy are you that we're starting to live stream this, because there's a breast cancer support group almost on every corner, and that's wonderful news. That's great, and that's why the survival rate for breast cancer is in the 90 percentile. We want to get there someday, but there isn't a lung cancer support group on every corner. This beautiful lady drives up from San Diego to be here. So we got this crazy idea that because this was helping so many people and we were doing such great things, that we would start to live stream it. So for all you patients that have dialed in, whoever has dialed in, hello, welcome to the living room. And now you're part of helping other people get the care that you're getting. So be proud of yourself that now you're doing what we do in a big way. So thank you for participating in this. So bravo to you. Linda.
She might need a mic.
Oh, you need a mic?
I have a loud voice. Hello to everybody, and it's not that we don't have support groups in San Diego, we do, but there's nothing like this place. It's worth driving 500 miles to come up here once a month. That's what I do. My daughter has lung cancer. She's had it now for 2.5 years. She had a scan about 2-3 weeks ago, and she's still stable. She was diagnosed at age 38, non-smoker, never even around smoke. We never smoked. So where did it come from? I don't know. But she's dealing with it so far successfully. She's stable. She even went back to teaching 7 weeks ago, and she's doing fine. So it's a wonderful thing. She's on Avastin. She gets it once a month. She has not become resistant to it yet. And I'm glad to hear that news, that if you do become resistant and go somewhere else, you can go back. So, there is more flexibility now and more things out there. So hooray for this group, because it's the best.
We have a mic for everyone moving forward.
Wasn't I loud enough?
Pass it on.
You were great. You were great.
There you go. I pass it on.
I'm Penelope, and a lot of you met us last month, my sister and I, Hannah. So this month we brought our mom. She's down there. She'll tell her story soon, which most of you know. But a lot has changed in the past month, and she's doing well. And I just want to say thanks to everybody for everything they gave us last month, because we were lost at this time last month. And you guys were all a huge help. Everyone offered so much support and ideas and everything. So we're so happy we found you guys, and thank you.
I'm Hannah, Penelope's sister, and same thing, a big thank you to everybody because this has been great, and you'll hear from my mom soon.
Hi, my name's Joyce, and I was diagnosed in December of 2011 with non-small cell lung cancer, stage 3B and inoperable adenocarcinoma, and did try to get samples of tissue through biopsy, but they didn't take enough tissue, or the tissue that they took was mostly no good. It was necrotic, and so I didn't get tested for a while. I had to start therapy, so I started concurrent chemo and radiation, and I finished the chemo in March, early March. The radiation was finished in early February. I just got back my first post-treatment PET scan and was amazed to learn that I am now cancer-free. According to one oncologist. The other one says no. I'm in this strange place. I'm between oncologists. I'm actually seeing the oncologist who got me this far and to whom I will always be grateful. But I also really like and just have a personal bond now with my second opinion oncologist. And she and he don't see eye to eye on much of anything, including whether or not I'm cancer-free or NED or in remission or what you call it. Also, the difference they have is my original medical oncologist wanted me to go on Alimta maintenance immediately. The other thoracic oncologist said, absolutely not. There's no data to support its efficacy. And I've been torn in between and talking to Danielle and got a third opinion, fourth opinion, and I can't deal with it. I decided to go for I'm going to sign up for a clinical trial that's being recruited for right now for a vaccine called Lucanix, and it's pretty exciting. The only problem is it's a double blind, so I have a 50% chance of getting just placebo. On the other hand, if I hadn't decided on doing this, the other plan was just to sit around and wait and see and do nothing, and that makes me too nervous. I want to stay cancer-free, and just to sit around and wait makes me a little too scared. That's my story.
Everybody's stealing the mic.
Pick a mic, any mic.
Yeah, you get to keep that mic.
Is it on?
And just a quick word about the mic, because we forgot to tell you. We want to see your gorgeous faces, so you can actually hold it right here.
Oh,
We're going to hear you. Let it roll.
my name is Peter. I'm here with my wife who had the cancer, and I'm just a tag along to try to help her.
Without him, I wouldn't be here, period, physically or mentally. I think that this has been a wonderful experience for us. I just passed my third, when we went, the scans, the CAT scans, and everything looks like it's very good, and I feel very good, and I couldn't have done it without you. So, thank you.
Wait, where'd you just get back from?
Huh?
Where'd you just get back from?
France.
Didn't you just go on a trip? You don't want to tell everybody about your trip?
You went to France?
Where did I get what?
We just got back from
Where did you just get back from?
France. And we went.
That's all.
But that's not newsy.
2 weeks in France, on riverboat.
It was good, but I'll tell you, California wine is so much better than a French wine.
Hi.
Wine helps you get over being cut up, losing all your hair, those kinds of things. It really makes you feel better.
Okay.
Because it's California.
Hi, I'm Christine, and my husband Philip, and two of our daughters, Penelope and Hannah. Somehow they found out about this when I was going through all my trials and errors, but I was at the point where I could hardly walk because I had so much fluid in my lung, and the doctor I was seeing just wanted to put me on chemotherapy right away. And we live in Mariposa, which is up by Yosemite National Park, and my kids, 4 of our children live here in the Bay Area, and they moved me here to our house, our old house that our son owns, and excuse me, and made me go for a second opinion, which I'm very grateful now. And I'm sure they found this particular oncologist through this association, which I'm very grateful for. 3 weeks ago, I had surgery done where they went in through my side and took out the fluid in my lungs. And within 3 days, they released me from the hospital after taking out 2.2 liters of fluid. And I just came from the doctors today, both the oncologist and the surgeon, and they were very pleased with everything that they had seen. The surgeon was surprised that I was out of the hospital in 3 days, but he took so much of the fluid out that there was very little drainage, therefore no reason to keep me longer in the hospital. And today, with all my blood tests, the doctor was very pleased with how I looked and how I was reacting. I've been on Tarceva for 13 days now. So far, I don't have to do any chemo or radiation. So we're really, really pleased with how everything's progressing. And I'm glad to meet everybody here, and I'm sure at some point I will know everybody's names. But I have to thank the group here for however my kids found out about it.
Well, you have to tell everybody that I think the girls found out about molecular testing here.
Yes.
And you got molecular testing.
I did have it done.
And she was EGFR positive.
Yeah.
And Christine, tell, because there's a couple other people I know in the room who have the same doctor, so you can say who it is.
Oh, Dr. Dormandy?
Mm-hmm. Yeah.
And I swear by him. My kids all swear by him. And he not only had to go through my questions and my husband's questions, but we have 6 kids. And they all had questions.
That's a lot of questions.
And in the hospital, the surgery was done at El Camino, and I have great things to say about them, except the food. But that's just about everywhere. Yeah, that's hospital food. But, I mean, Penelope has a 7-month-old little boy, and they allowed him in the hospital room anytime I was there. And, you know, we have 7 grandchildren, and they were in and out at will, and it made my recovery so much better because even like Hannah has a 2-year-old and Penelope has a 3-year-old, they knew Grandma was hurt, but they knew how to take care of her. They knew it was my left side. They wouldn't climb on the bed on my left side. They, you know, wanted to see, and of course I showed them what was going on, and they were very good about it. So I think keeping it into the family and letting younger children know about these kind of things was very beneficial because the kids weren't upset that Grandma was hurt. They were trying to take care of me. But thank all of you for all the help that you've given us so far. And we'll be around to help a lot more. Thank you.
Awesome.
Hello, I'm the other half, Philip. Anyhow, I basically say we are very, very grateful for finding you folks, and very grateful that we were able to get a second opinion, and we're able to get out of, I'm not going to say that, changed insurance, so we were able to get over to Dr. Dormandy, because to us he was a lifesaver for us, and just for the fact that we were able to find out what her gene was coming to EGF or EFGR, whatever that is, I'm sorry, positive, so we could go straight to Tarceva. That was, to me, like hitting a home run. Yes, it was.
That is a home run.
We were very reluctant, wanting to go to the chemotherapy, and once we found out she had the positive gene for this Tarceva, we feel real good with it, and I know we've talked to a couple of people here already that's been on Tarceva that had been very, very successful with it, and we're just hoping and praying for the best. So, again, thank you very much, and we will be regulars.
Hi, I'm Jennifer. I guess I definitely hit a home run here. EGFR positive. I've been on the drugs for about 7 months, and I just got back from the oncologist doctor a couple of days ago, and my CEA level is 2.
Awesome.
So I'm very happy, but what makes me nervous every day is when is it going to creep back up, right? So my question to some of you is there anything we can do proactively? Diet, exercise, certain type of food? What makes one patient can be successful in Tarceva longer versus other? Do you know what I'm saying? Why some works for 2 years and some works for 7 years? What really make a difference? And I'm really curious if there's anything we can do outside of taking Tarceva. You know, what can we do? You know, from within our control that we can, you know, manage to make the drug more successful, right? Is there anything we can do? You know, perhaps a certain diet or certain exercise. I mean, I've been reading a lot about anti-cancer food, you know, diet, and I've been told exercise is tremendous to making the drug very successful. I was told that try to keep your weight down will make the drug more effective. My cancer dropped significantly very fast within just a few weeks, and part of the reason the doctor said is because I was dropping my weight and I was exercising 2-3 hours a day, and he said that has a lot to do with it. So I thought I should share that with some of you, is that certainly exercising and you know is a factor in making the drug more effective. So I don't know if there's any helpful hints that you guys can recommend. I would love to hear about it. So
we can share a little bit of that later, but you're on the right track. You are.
Hi, I'm Chris. I'm just give you a little more context about Jennifer's condition. Jennifer was diagnosed just over 6 months ago. This was 3 weeks after the birth of our son, who came a month early. During Jennifer's last trimester, she was coughing a lot. The assumption was that she had acid reflux from allergies and being pregnant. Pretty soon after the birth, it was obvious that wasn't the case. So it started with an X-ray, followed up with CT scan, straight to an oncologist. He immediately did a needle biopsy, not sufficient to diagnose exactly what it was, but it was confirmed cancerous. He rushed her in for surgery to remove a lymph node so they could do path work on it. While we were waiting for those results, he bet that she was EGFR positive. She's not a smoker. She's Asian. There's a large... Yeah. She's not from Wales. There seems to be a larger correlation with Asian female non-smokers who get EGFR positive. So on a guess, he put her on Tarceva on a Friday. Come Monday, we went back to the oncologist. Still didn't have the results back. She'd stopped coughing. We thought it was psychosomatic. He's like, no, actually, if you do react to the drug, it's going to stop very quickly. Jennifer's, so it is stage 4. She has it not only in the lung, she had it in the brain, small lesions in the brain, liver, bones, and lymph nodes. So there was kind of these triple path treatment, figuring out exactly what type of cancer she had, trying to deal with the brain issue, and throwing her on Tarceva at the same time. So Jennifer did CyberKnife at Stanford University, or Stanford Hospital, to treat 4 lesions. So far, that's shown to be successful. She's had two repeat MRI scans since then, and she's clear. And her CEA level started at 480, and it's pretty quickly dropped down to 2.
Awesome.
Hello, my name is Bill Morris, and I'm here in this wonderful place to support my amazing wife, Christy.
I'm Christy Morris, and we've been coming now for several months, and throughout this journey have gotten help from the Addario Lung Cancer Foundation. Outside of this group, Danielle has been wonderful, and I was diagnosed in late 2009. I'm a never smoker, and it's non-small cell adenocarcinoma. Later on, we did the tissue testing, and I'm negative for all the big three. EGFR negative, I don't have the ELK gene mutation, and don't have the CRAS gene mutation either. Although I was on Tarceva for a while, and it worked for a little while, apparently there's a wild type where it can work. But and when they found it, typical to many, I had a dry cough and a series of odd other symptoms. And I thought the cough was from postnasal drip or allergies. But luckily, I had a primary care physician who said, well, you're probably right, but let's do a chest x-ray anyway. And then after the chest x-ray was the phone call that said, well, no, there's something there, and we need to do a CT scan. And we were off and running from there. At the time they found it, it was many tumors in both lungs and many tumors in the bones, but nothing in the brain. So our battle has been the lungs and many different bone locations. And the hot area right now seems to be the bones, but I haven't had the pain. They keep asking me, do you have any pain? And I said, no, I don't have any pain. And so I did the, because of the nature of the tumors and where they were, I went straight to chemotherapy and did the traditional carboplatin, Taxol, not so traditional Avastin, and then pamidronate to toughen up the bones. And then continued with Avastin and pamidronate for a while, then went to Tarceva. And right now I am on small doses of Taxotere. I tried Alimta, it did not work for me. And so I am, it's a 3-week, it's a regimen in 3 weeks and then 1 week off of Taxotere. They say I'm gonna lose this hair again, but for a while it's just been getting kinkier and more afro like my husband. So they say that, that if you've been married long enough, you start to look like each other. But
well, hopefully he's going to look like you.
Yeah.
Right.
But apparently at some point I'm going to lose this again. So I'm prepared. I'm getting myself psychologically ready. I lost it the first time. It grew back, curly and gray. And so my body's tolerating this. There's fatigue, and by the 3rd week, I'm a bit beat down. But the 4th week, I recover and I'm back up. But I'm able to live my life and take care of things at the house and things we're involved with. And I'm trying to do exercise and eat right and all those things that are adjunct to the medical treatments. Yoga through there's another organization, the Cancer Support Communities in Mountain View, and I've been involved, been going to some yoga programs there. We've had first opinion, second opinion, third opinions, fourth opinions. I think I've seen 4 doctors altogether in this journey. So I'm 2 years and 4 months into this, and I'm beginning to think more and more about the cancer as a chronic disease. I know that's kind of what we've been talking about, that it, like a heart disease or diabetes, that you live with it and you manage it, but you live with it. So far so good, and I do have a wonderful support system, family, very close family with me, and parent and brother and lots of friends, and So all of that, I think, is really help. And my last PET scan was, I think it's pretty miraculous. It was in February, and I had been really kind of off at any treatment. And the cancer was smaller and less active, and less metabolically active. My next PET scan will be in mid-May, and I'm hoping that I'll get the same result, that I'll see on the inside what I'm feeling like on the outside. And so I think this group has been great every month, and to hear the stories. And I am a great note taker, and I fill up my book with notes from all of you. So thank you all. This has been great.
Let's see, I'm Laurel Deb. I'm the patient, but my husband does the talking, so I give him the mic.
It's usually the other way around.
It's usually the other way around at
Yeah.
home, too. Well, I'm a camp follower, as my wife said. She was diagnosed about 6 months ago with,
October.
well, that's almost October.
We get it. Yeah, that's the way it should be. Right.
But she was diagnosed with 4th-stage non-small cell lung cancer, and she went through the chemotherapy with Alimta plus chloroplatin or something like that. And now the last couple of times she's just doing Alimta as maintenance. I want to thank Danielle particularly for getting us into our second opinion doctor at UCSF when they couldn't take us for weeks. UCSF, I'm sorry. When they couldn't see us for weeks until she got on the phone and got us through. After answering my call as she got off the airport one time in Washington, D.C. So it was very much appreciated. The second opinion completely agreed with the first opinion doctor, which was nice. And they said, and both of them said, try the Alimta first. If that works, great. And if not, we'll put you on the Tarceva because she is EGFR positive. So we have at least one good thing going for us. And meanwhile, she's able to drive again, which she couldn't for a while.
Because I'm finally off of morphine.
That too.
So sleepy.
Yeah, she's very sleepy with the Alimta stuff. It doesn't seem to, she's not completely back, but she can drive, and she can go up and see the art exhibits in the city, all by herself, or with me. But she.
I don't drive to San Francisco.
No, that's by bus, and she's coming along better all the time. She was diagnosed as being cancer-free after a half a dozen treatments with the 2 cancer agents, anti-cancer agents. That's pretty much it for us.
Awesome. That's great.
Christine, my daughter Jennifer, I believe, contacted Penelope to tell about this group. So it was sort of indirectly, and I was wondering I didn't have your name, who was the person. I found this group in 2008. I was desperate to find any group that had information and was doing something about lung cancer. Where I live, prostate cancer, breast cancer, there was everything, but nothing. This group has been wonderful. I'm not able to make all the meetings, I live a distance away, but I try to come to at least half of them, and we have a great group of people in the support system here. I have BAC lung cancer. I went through response genetics on the genetic mutation testing, and I also tested EGFR positive, and they indicated to me strong presence with Asian and some Mediterranean background. They thought someone in my family had lung cancer. I don't know of anyone, but you don't know 3-4 generations back when they'd say influenza. Possibly that was lung cancer. And I have learned so much with this group, and it's just a special part of my life. And welcome to all our new members.
Thanks, Beverly. I was diagnosed with the 4th stage lung cancer that had metastasized to the brain last May. I'm coming up to a year, which is pretty amazing. And I've had the rounds of chemo, the strong chemo, and then I went on maintenance. And I was not EGFR they couldn't get a proper biopsy, so it was unknown as to whether I would be qualified. So of course, after I finished the chemo and I keep wanting to have the biopsy, then apparently, all the cells were necrotic and there was nothing available. This is what I've been told. So my doctor decided to start me on Tarceva anyway, even though there was a lot of unknowns. So she put me on 100 milligrams then, and then when I went to test to see how I did on the 100 milligrams, I found that my large lung tumor was stable, but I had developed a tumor another one in the brain area, a few in the brain area, and one in the other lung. So the way we're treating that right now is with, we upped the milligrams to 150 milligram of Tarceva. And now I've been on that now for not knowing whether I was even eligible. I mean, I've been doing this, it's about 8 weeks now that now I'm on the increased Tarceva. I feel better. However, they did address the small tumors in the brain. I went in for the gamma knife procedure last Friday, and apparently they went in and were able to get 4 tumors eradicated. So it's a wait-and-see game. I mean, I've talked to my doctor again about getting this biopsy, talking about the blood tests that I know about that would show that I had that compatibility. And even when she talks about getting the biopsy, that one of the tumors is too close to the diaphragm. So then I think of the other evening that we spent here talking about that bronchoscopy apparatus. And so it keeps me well informed. However, when I talk to the doctor, I feel as though she tightens up right away, and it's really these things hadn't been totally approved by the hospital, or, apparently the hospital takes a large position on, I don't know, what do they test once you've actually had the chemo? Are there tissues enough to actually test? So right now I'm in the waiting game. On the 1st of May, I have all of the tests. I'm having the PET scan, CAT scan, everything. And, there's a lot of unknowns right now but I'm here and I'm thrilled. I just feel so lucky that I found this group around the corner. And it's unbelievable to believe that this is around the corner for me. Thanks a lot.
Hi, my name is Lynn, and this is my second time here. I was diagnosed back in May of 2011, stage 4. It had metastasized into my left lung, liver, abdomen, all of my lymph nodes, so I was in pretty bad shape. My CEA cancer tumor count back then was 1,300, which was quite high. Started, according to my oncologist, he didn't feel like I was a candidate for the Tarceva. He wasn't quite sure, even though I'm Asian and I should be in that group.
Are you?
Yeah, I'm Asian. So anyhow, he went on a hunch and decided to immediately start me on chemotherapy. I just completed my 15 rounds of chemotherapy yesterday. Still have my hair intact, believe it or not. I'm very grateful for that. I did the first line of chemo. I did 4 major first line of chemo with carboplatin, Alimta, and Avastin. And then my body was it's really harsh, so I asked him to just slow it down. So we did the scan in the end of August, and it looked really stabilizing, so he decided to put me on maintenance in September. So I had my 11 rounds of maintenance as of yesterday with the Alimta and Avastin combo. Besides some of the bad days, I'm out every day, driving, doing whatever. I travel every month to some city doing something. I refuse to be, a non-believer, non-liver, living with this cancer. So I hop on the plane and just take a trip wherever I feel like going. And then I come back and I do chemo. He told me I can go wherever I want to go, just as long as I show up for chemo every 3 weeks. So I've been doing that. I've been managing this last 2 rounds of chemo has been really good for me. I haven't felt any major side effects. So up and running, and going to celebrate my birthday tomorrow with my family. So.
Oh, yay.
Didn't think I was going to make it. Didn't think I was going to make it this far. And then next month will be my 1-year anniversary with this cancer. So we're going to continue with the chemo until the day that it stopped working, and then he will decide to put me on Tarceva, even though I don't have the genetic mutation for it, but he's going to go down that road when we cross that road. So I just learned to take a look at life differently now and started to accept, like you say, this is a chronic illness, and try not to let it take over my life. And and I think with that in mind, I just feel stronger and get on a positive road and just let it be, because it is what it is. And I didn't think I had 11 months of good days, and I did. So just keep going, and regardless of having the genetic mutation or not, we'll just take it wherever it goes. So, right. And I'm back.
Hi, my name's Tina, and it'll be a year and a half in May that I was diagnosed. I started out on Tarceva for 2 months. Joyce, my thing is very similar to you. So it was 3B, inoperable, and after 2 months of Tarceva, then I did chemo and radiation concurrently, and finished up all the chemo last June. And then I was put back on Tarceva again. So I've been on Tarceva since August of last year. And so far so good, but I'm coming to a decision probably in August about going off Tarceva and seeing. So far my scans have been good, no evidence of disease, so no active, nothing going on. So just hope it stays that way.
And who just had a birthday party?
And I had a birthday party. Yes, I did. And I wanted, instead of gifts, I said, why don't you just write a check to the Lung Cancer Foundation? So, yeah. So it was pretty fun. It was bubbles and burgers because, as you have found out now, I guess wine is fine for lung cancer patients. So my favorite is champagne. So we had champagne and hamburgers. My favorite things.
That's a good thing. That's a good thing.
Yeah, it was very fun. Very, very fun. I mean, every birthday is pretty special now. So, and I am so appreciative of this group. It's really wonderful to be here. Thank you.
Hi, I'm Sally, and I'm a big proponent of early diagnostic testing if you're at high risk. I put myself into the International Early Lung Cancer Test, and because I have my mother, her brother, my paternal grandfather all have had lung cancer, and I had smoked for 30 years, but I had quit for 20. So in 2004, I entered the study and knew I had nodules in all my lobes, but was told they were benign and they would watch them. And in 2009, one of them grew. So I ended up having the lower right lobe removed, and I was very fortunate because of early detection. I was found at stage 1A, and I had adenocarcinoma, non-small cell, and I didn't need any further treatment, and I just celebrated my 3rd anniversary of being cancer-free.
Hi, my name's Rebecca. I think it was like 7 years ago that this place found me. I was in a medically induced coma for about 2 weeks in the ICU at Sequoia. And when I got out of there, Bonnie burst into my room with a rose. And ever since, I've been here ever since. I started with, my voice is very bad these days. Besides the surgery, it's also the hay fever. I started about 8 years ago with a chronic cough, had the acid reflux diagnosis, allergy diagnosis, on and on for about a year, and then finally got a hold of a pulmonologist who knew what she was doing. And I was on the classic carboplatin and all of that, and then radiation for 6 weeks, and then they took my left lung in May of '06. Okay. And then I started Tarceva, and I've been on that ever since. So my last scan was about 2 months ago, and Terry came in and said, your scan is gorgeous. So I'm in good shape, and my husband and I are going to celebrate by going to Italy and Sicily next week. Anyway, that's my story, and I'm glad to be here. And it just shows that Tarceva does work. So stay on it if you're on it. I'm on 150.
Sally and Rebecca are our mascots. They've been here from day one, and you know that's just thrilling to see that.
Before Carrie starts, I just want to, my sister just came over and handed me like this news bulletin of people that are online, and there's a couple of comments that I'd like to read to everybody.
Oh, great.
And it's actually super cool. It makes me really happy.
Okay, cool.
So Patty says that the audio and picture are so clear, and she really feels like she's here. Kathy says, I'm hugging Jennifer right now, but she doesn't even know it. And Bob says, I eat blueberries by the truckload. I got stuck on them during my stay in the hospital for my surgery, and now I am still stuck on them. And Alicia says, happy birthday, Lynn.
Oh. Well, let's say hi to all these folks that are dialed in, okay? Hi. Let's give them a big shout out. Thank you for calling in. Awesome.
Carrie, you're up. Hi, my name's Carrie, and I was diagnosed in October of this past year with adenocarcinoma stage 4, and have just finished 6 rounds of the hardcore chemo, Taxol, carboplatin, right, I forgot it, Avastin. I made it through 5 of them with the Avastin, and then I had a TIA, and I'm interested to know other people's experience with that. But I was in the hospital for a couple days, and quite a scary experience to think that I was at stroke risk and various things. So as a precaution, they removed the Avastin from the mix. He was planning to have Avastin be my maintenance, so I don't know why that was. So again, I was hit a little hard saying that what they thought was going to be my maintenance now can't be my maintenance, so then limited, not eligible for the Tarceva, but do plan to start a Limtez maintenance chemo next week, along with Zometa that I'll continue on for the bones. So that's where I am right now. And I did manage to go on a cruise. I think when I was here last, I said I was packing for a cruise, even though I didn't have one planned.
Exactly.
See?
Exactly.
So,
Yes.
trying to keep my spirits up, but I am very tired also, and I'm interested to see how I feel on the maintenance chemo, and hopefully able to function better than I have been.
Well, I'm Carrie's favorite uncle. Of course, if you know her other uncles, there's not much competition. Anyways, I am just supporting her any way I possibly can, and I thank you guys for this group.
Well, a number of you probably know who I am, but there's a lot of new faces here, and I'm really delighted to see that the word's getting out about Bonnie J. Addario's Lung Cancer Foundation, because I think these guys are absolutely invaluable in helping getting information out. I was diagnosed almost in 2009, and it took almost a year to get diagnosed. I was told that I had acid reflux. I was told that I had allergies and all these sort of things, until finally I was having to prop myself up because I was coughing up so much fluid. By the time a doctor got around to doing an x-ray, there was a golf ball sized tumor. I went in and had my lower left lobe taken out, and at that time the surgeon said, you're cured, you don't need an oncologist. Unfortunately, 18 months later, my disease proved him wrong and came back, and so it went to the other side of my lung, so I'm stage 4 essentially with that. Had a wedge resection for that. I started immediately once I was re-diagnosed with my memory. She's not so good anymore.
That's
so
okay.
that's kind of a chemo thing.
That's okay.
But I started, my first round of chemotherapy was Alimta, Tarceva, and I'm sorry, it was carboplatin, Gemzar, and Avastin. And then I went on and I was on Avastin for a while. as maintenance. I also had an oncologist, and I decided to get a second opinion, and also they differed in their opinions. And my first oncologist tended to play it safe and kind of did what she felt comfortable as being standard of care. And unfortunately, I was kind of getting the feeling that, you know, they were kind of going down the palliative path. And I'm like, wait a minute, I'm 40-something, I'm a non-smoker, how can this be? How can something like this happen? No smoking in my family, no history of cancer, all these sort of things. And by the way, my diagnosis is adenocarcinoma, bronchoalveolar carcinoma. It's a rare type, and it sounds like a lot of people in here seem to have that. I don't have the pure type, but it's mostly BAC with some mixed. At that point, my second oncologist strongly suggested that I get molecular and genetic testing. I firmly believe, and I am a very strong advocate of getting this, and ideally, hopefully, they can get to a point where they're doing the molecular and genetic testing before they start chemo, because I firmly believe that if they had known what they knew after they did the testing, my first round of chemo would have been very different, because the carboplatin was one of the more toxic, and they found out that my disease was actually resistant to it. So they did the testing, and I feel even though we didn't get a lot of information from it, it was certainly more information than we knew before. My oncologist decided to kind of take a chance on me, because he said that he had seen my profile before, non-smoker, BAC, the way that just my profile was. And he said, you're wild type, which means that I did not have I was not positive for EGFR or really anything. But he said that I want to try you on a clinical trial that combined Alimta and Tarceva. I'm now on my 41st round. I had to go off the Alimta because although it's not shown in the documentation of the two separate drugs, that's why they do clinical trials. I think that there is some type of synergy that these two drugs may, or in my circumstance, started having a little bit more toxicity, because my creatinine level went from 0.6 to 1.58. I started having intestinal issues, all these sort of things. Last year was rather difficult, having edema and those sort of things. So my oncologist, after talking to my my kidney doctor, I forget what the specialty is. Anyway, they decided to take me off the Alimta, and I've been on Tarceva alone for, I think, 13 cycles right now. And he makes it very clear that even though I've had a complete response, and he calls me his poster child, he makes it very clear to me that I am not cured. My disease is stable, but it's being managed. And so I have active disease that we're managing. And so I essentially am looking at being on chemotherapy for the rest of my life. And there's a number of reasons for that. But I am very grateful. I'm wonderfully ecstatic that I'm an outlier as far as the statistics, because I used to be in biotech, and I did a lot of the analyses of various different drugs, and I knew what the statistics were, and they scared the hell out of me. And you know, one of the scary statistics was for stage 4, basically survival was for 1 year was 5%. And so hopefully all of us here are going to prove that type of statistic wrong and improve those statistics. So all I have to say is that, you know, there are a lot of new drugs coming down the pipeline. If the Tarceva, God forbid, stops working for me, there's another test that I can do. I think it's ROS.
ROS, RET, T790. There's
right. Exactly.
Lots of things going on.
So I would, if you're newly diagnosed out there, I would go to your oncologist kicking and screaming and insist that you have molecular and genetic testing. I firmly believe I'm sitting here alive today because of that, and because my oncologist was willing to, you know, not just be safe and play it safe and do standard of care, but really try to do something and save my life.
And who was that did all that stuff?
Do you want me to say?
Yeah, say it.
Dr. David Gandera,
Yay.
UC Davis, and he is absolutely phenomenal. The other thing I firmly advocate is participating in clinical trials, because the more data they can gather from people like ourselves, hopefully other people that follow behind us can gain from that type of experience. So there's nothing but upside as far as I'm concerned with clinical trials. So, yay!
Yay!
My name is Reed. I'm her husband. She's the patient and she's the talker.
You tell by the hat. Or can you tell by the hat?
Yeah, right. The hat.
So I am Jane. He is my wonderful caregiver, and it's a great job. I was diagnosed in August, last August. I had a spot on each lung, and it was by accident. I'm an aerobics teacher, and I hurt something, and they found it by accident. They think maybe it had been there 4 months. So I ended up having surgery, a wedge resection and a surgery on the left lung and a lobe removed. And then they found one of the lymph nodes had positive. So they gave me 4 rounds of chemo. I don't remember what they all were, but I did that, then had a scan, and it had metastasized. That didn't work. So that it wasn't really 2 separate lung cancers. It had metastasized initially to the liver. So now I just went through my 4th round of what you're taking, the Taxol, Carbo, and the that's when I lost the hair and all that stuff. Anyway, which is fine. So I get a scan at the end of April to see if I had a scan. They had started to shrink. I get another scan at the end of April, and she says, hopefully it's the same, or they've still shrunk, as long as they haven't grown or moved anywhere else. So that's where I'm at. We do thank you, Daniel, very much for getting me into Dr. Gandera. We had a second opinion and went up there after my last chemo, and he said I'm on the right track. He wants to do a little more testing, but he's a great guy. So he says I'm now his patient also. So we're happy with that, and we're great. I love this group, and I thank you all. So that's my story.
Hi, I'm Mary, and I was diagnosed with stage 4 non-small cell lung cancer in October of 2010. And right away, my doctor put me on carboplatin, Alimta, and Avastin. And I think I had like maybe 9 rounds, and then the maintenance was Avastin and Alimta. They took me off the carboplatin. And I forgot to say that when I was diagnosed, I had 1 tumor on my lung, and then it metastasized to my spine. And since I've had the chemotherapy, my spine has not lit up, and so that was good. But what happened to me, the chemo, and then the tumor really shrunk down. But what happened was the chemotherapy caused kidney problems, and I came about this close to having to go on dialysis, and my creatinine went up to like 5.4. And when you're at 6, you go on dialysis. But now it's down to 2.2. So I'm recovering, like it's been 9 months, I think, since I had chemo. And then, but I had to go in the hospital for like 10 days in September because of the high blood pressure from the chemo and the creatinine and all that stuff. And I survived. And then in November of 2011, right after I'd been in the hospital, I started target radiation on the tumor. And I haven't had any treatment since that. So in January, I had a PET scan, and they saw some suspicious spots. And then they said, let's wait and see. And then just this week, I had another PET scan. And there was like the spots on the left lung were gone, so my left lung's clear. But then there was some little spot that they were concerned about. And so it went before the tumor board at Stanford just today, and they said they're not sure what it is. It was lit up a little bit, and they're not sure, so they said, we're not going to put you on Tarceva and do radiation. Let's just wait 3 more months, which I'm thrilled about, because I've been living a wonderful life for the last, 4.5 months, not having treatment. It just feels great. And I exercise an hour every day rigorously, and I really believe in that. And I guess that's it.
you think of anything else?
Oh, I can think of a lot of things, yeah.
Oh, okay. So I'm going to put on my partner here who is really taking care of me.
Ray.
Yeah, we found out October it was just a day or two before our anniversary. It was quite a shock that happened. But just to highlight a couple things Mary said about the kidney problems, they think it came from the Avastin and Olympta, either one or both of them together, whatever. But it got to the point where, as Mary said, we were getting ready to go into dialysis. We're reading all this stuff, not only about lung cancer, but about dialysis and how you take care of it. We had just gotten back from a trip from Canada, and she wasn't feeling well that night. And what happened during the night was she had complete kidney failure. Her blood pressure shot up way over 200. And my brother, who happens to be an MD, came. I said, "Larry, come over and take a look at her." And he just looked at me and said, "Call 911." And we took her to the hospital. And Mary was in intensive care for 10 days. And intensive care at Stanford is
3.5 days.
And well, okay, yeah, is one nurse and one patient 24 hours a day. I mean, they don't let her out of her sight. It was a pretty harrowing experience. And so, like Mary said, we're happy with creatinine level down at 2.2. I mean, that's, normal is 1. She's at 2 or less, and she's at 2.2. So the other thing that was just something that happened today, Mary had a PET scan, and the initial radiologist looked at the scan and said, "Oh, you have a new tumor. It's 1.7 centimeters." So today they took it to the tumor board, and another radiologist who's on the tumor board at Stanford looked at it and said, "Oh, no, it's not clear exactly what it is. So we're not going to do anything." And then our doctor just said something at the end. She goes, "Radiology it's still a big part of it is an art, not a science." And it just sort of hit me. It's like, wow, I guess I knew that, but it really, these things aren't just cut and dry, 1-0. It's still it still all boils down to an interpretation by one person. And I guess that's why getting second opinions and asking lots of questions is so important.
Exactly.
So there's a couple of, what I think I was picking up on were specific questions coming from people tonight, and everybody was being really respectful and not asking them and letting everybody take their turns. So I'm going to go back to them, and then if I didn't pick up on it, please let me know. But starting with Jennifer, I think you had a question about Tarceva, and if anybody has had any thoughts on how to help Tarceva to work better for you. And I know there's several people in here, Elizabeth included, who's insanely boisterous these days, which I love, who might be able to help Jennifer either now or after or something. But her question basically was, Tarceva is working really well for her right now. Has anybody heard of anything, or is anybody doing anything in particular that they feel might be helping the Tarceva to work as well as it has been?
Do you want me to comment?
Sure.
I know where you're at. It's difficult. I might give you a little bit of caution, because there are a lot of different things out there where people are talking about, Chinese medicine or antioxidants or various things like that. I would highly, highly suggest that if you want to undertake anything, that you discuss it with your oncologist first, because there are a couple things that can happen. you could inadvertently, with some of these medications, even though they're natural, they still are medications. If you think about Taxol, it's actually from a tree. So even though they're herbal or natural or supplements, you could inadvertently cause two things: either your chemotherapy to be inactivated, or you could stimulate your immune system so that your autoimmune starts kicking up and you start getting a lot more side effects, so much so that you won't be able to essentially, weather the toxicities of these poisons. Is essentially what they are. So even taking, like the gentleman talked about, things like blueberries, you don't want to take a lot of antioxidants when you're on chemotherapy, because antioxidants essentially neutralize the chemotherapy. So, you need to really balance things. I take a number of supplements, but I do so carefully. I use probiotics because when I was on the Tarceva and Alimta, it caused a lot of intestinal issues. And so it can really throw, your intestinal tract off. Our Tarceva does have a lot of the intestinal issues. So that's something that you want to work on. Probiotics, there are various different ones. Actually, there's a great little natural food store in Palo Alto called Country Sun, and there are a couple people there, and I'm not advocating it, but I found the people there very helpful and explained to them what your situation is, and they've helped me with a number of things. Matter of fact, I've been having a lot of joint pain and things like that, and who knows whether it's from the menopause because the chemo threw me into menopause, or whether it's, there's just so many things that goes on, but they gave me something to try for that. The probiotics essentially they're things, it's kind of the little buggies in your intestines that should be there to keep things in balance. And so this helps maintain the environment in your intestine and your gut to be more where it should be. So that's something, taking calcium. I'm osteoporotic probably because of the chemotherapy, so you want to make sure that you're taking things like calcium and vitamin D, which is a great combination. Rebecca?
You can get it in yogurt.
Yep.
And I also take Gerodophilus, it's J-A-R.
Change the mic.
Right.
Yeah, a lot of them, because a lot of them you have to keep in the fridge, but the Gerodophilus is stable.
Right. I take one that's in a capsule that has various different ones in it. You want to kind of get a broad spectrum because, again, you're trying to get a good healthy gut. So things like that. Eating things like yogurt are good, but I'm talking about huge amounts of the probiotics, and you take them, and now I only take it maybe once a week or something like that. At first you may take, once a day or a couple times.
Twice a day.
Oh, okay.
And it has something like 50 billion.
Yeah, right, exactly. Just a huge amount of the little.
It's Gerodophilus.
So when I told my doctor about my GI problem, he said, "Oh, just get on this drug called Creon, C-R-E-O-N, and it's some kind of enzyme that's prescribed to people with pancreatic cancer." It works great. It's a little pill, and I've been on it for a couple months, but it's just, if you read the description, it's for a cancer treatment, so it's, that's why I'm curious if there's a probiotic. Seems more natural to me than getting.
There's one out there called Activa, which is a yogurt, and that's very natural and very good as well.
Be careful with that though, because that made me explosive.
Oh, really? Okay.
See, the problem is
Well,
that then you
yeah.
have sugars and things like that. So
there's a fine line between explosive and
right. Yeah.
and not.
So it's just that sort of thing. But it's just really, you don't. I know you're very frightened about the cancer, and rightfully so. But you need to kind of choose an approach and really stick with it, and find an oncologist that you trust and work with them with it. And unfortunately, they don't have a lot of answers. A lot of things that I've found out, I've passed on to him. And he's just, like I said, I'm kind of the poster child, and they're kind of learning, what's happened. And so it's been a trial and error, but you don't want to be taking, a lot of the Chinese herbals and, the asparagus diet or the blueberry or whatever to extremes, because you inadvertently could be doing some things that you may not even realize that are happening. So you need to really work with your doctor on anything you do. I mean, I can't fault, exercising. I think that's the best thing in the world. Right. And, drinking lots of fluid, absolutely. When you're on chemo, especially, even if you aren't thirsty, just drink. You just need to stay hydrated.
What about detoxing? Is any one of you doing detoxing technique?
No. Actually, they said not to. When I was actually on the hardcore chemos, they actually said not to because it could release them into your system and make you even a little bit more sick. So, unfortunately, there's no hard and fast rule. It's just, just be very selective about what you're doing.
Mm-hmm.
Be very mindful. That's all I can
For some
say.
of us that are cancer-free, do we stay, is anyone trying to stay detoxing, like, eat a lot of vegetables and cut down on meat, honestly, you don't get this kind of direction from your oncologist. They just tell you, "Oh, go live your life as normal,"
I don't. You shouldn't be eating a lot of meat. I don't think.
No, the best thing to do is really moderation. A little bit of meat, a little bit of fish, a little bit, vegetables. Really balance.
Balanced diet.
I think what you really need to do is really look for balance. Not too much sugar, not too much salt. We know what's right for us and what's not. Right. We really do, regardless of what we like to do. Right. So balance is really good. And on the vegetable side, it's all the really bright vegetables. Right. Bright yellow, bright orange, bright green. They're the best for us. Mm-hmm. Vitamin D, acupuncture is very good, very good. Vitamin D is good. Somebody else mentioned vitamin D. That's huge.
Why is it?
Because the chemo depletes your body of vitamin D, and vitamin D is a bodybuilder, so it's something that, vitamin D is something that they always told us to eat a lot of Wonder Bread when we were kids to get vitamin D, because vitamin D is just a nutrient that you need. But chemotherapy is very toxic and it's poison. So while it's destroying the chemo, it's destroying the cancer, it's destroying a lot of other goodness in our body. So we have to make sure we replace those good things.
So if you're on Tarceva, it's not like chemo, but it's still a good idea to take vitamin D?
Still a good idea, because still it's foreign to your body, and it's still...
Yeah, Tarceva is
it's chemo, it's just not toxic, and it's
They don't classify as chemo.
It's considered
targeted therapy, not
right.
chemo.
But it's
right. But
it's like
it's still therapy, and it's still toxic.
Yeah,
anything that makes you break out in a rash like that is toxic. Doing something to you. So just common sense. Do the right things. If you're normally, like a snacker, don't snack. Eat multiple little meals, all day, and balance. Get all the things that you're supposed to get that your body needs to be healthy.
And I actually have a list, Jennifer, that I can give you of complementary therapies. We had a speaker, I don't remember if it was last year or the year before now. He's an MD from Stanford who's involved heavily into the integrative medicine. I can give you his information as well as a list that he gave us of some complementary type.
Right, yeah. I guess for me is, why Tarceva works for someone, different time span, how, is there anything people do
honestly, I don't think they really know yet. Yeah. To be really honest, I don't know how many of you have gotten on to our website, but I really want you to go look at a particular guest speaker we had, David Gandara. Have you looked at his?
No.
He talks about how unique each and every one of us are. And he asked everybody in the meeting, he said, how many different types of lung cancer do you think there are? And some people raised their hand and said, 3, 5, 7. He said there are as many lung cancers as there are people that have it. Wow. Because each one of us are so unique. Just like your fingerprint, we have a body print, and our biomarkers are all different. So we all respond differently to every therapy. It's not just Tarceva. Right. It's crizotinib, it's carboplatin, it's Alimta, it's Avastin, it's Taxol. It's all of the things out there. So, and there are biomarkers yet to be discovered. So When the entire genome is discovered, we'll probably have a lot more information about that. But while we're moving now, we have to just kind of go along with what we know.
And sorry to interrupt, but Kathy Parker, who's online, I'm
Hi,
so
Kathy.
sad she's not here right now because she would be a huge help in answering a lot of your questions. But one thing she did point out is that Donald Abrams, who's the integrative oncologist up at UCSF, she's saying he could answer all of these questions. And Kathy, just so you know, I have emailed him. I haven't heard back from him, but I have emailed him. So he might be a good point of reference for you too, as far as integrative oncology goes.
And don't discount that. You know, don't discount that at all. But make sure it's in conjunction with what your oncologist is approving too, because to Elizabeth's point, some of the things can throw other things off. So your oncologist always need to know what you're doing that's outside the norm. But I'm a big believer in integrative medicine. I actually see a doctor in Nevada. He's an MD, but he decided a long time ago that he loved alternative medicine, and he just really believes in, you know, vitamins and you know, testing you constantly to make sure your body is in balance and that, you know, all of your markers are where they're supposed to be, and just kind of keeping you healthy so you can fight all these toxins that are coming into your body.
Right, I mean,
So
that makes sense. You would think, I mean, you constantly kill, I mean, Tarceva is constantly killing cancer cells in your
And that's why
body,
a
and it's
balanced
highly
diet
toxic.
is good
Yeah,
too.
so,
You know, we know what's good for us.
Right.
Sometimes we like to cheat.
Right.
More often than not, we like to cheat. You know, and say, well, I'll just have a little soup for dinner, and then I'll just go get the coffee ice cream out of the freezer. And that's okay. But,
Kathy
you know, balance.
also says she'd like someone to pass her a glass of red.
Oh,
and
tell her.
Bob says red or white, but not to forget the blueberries and the pineapple. And then Nita chimed in, and I don't know if it's acai, like I don't know how to say it.
Oh yeah.
But you guys know what I'm talking about, right?
Yeah.
And then Bob just fell off his chair laughing.
Oh,
about
I
the
love
comments
it.
that are happening online.
Oh, that's cute. That's great. That's great. This is good. This is really good. What camera can we look into to see all these people that are online? Is it this camera? Okay. Would everybody turn around and say hi to all these people that are so darling, calling in and being so...
He's pulling out.
Correct. Politically correct.
There you go. Hi, everybody.
Hi, guys.
Okay, so just for the sake of time, Beverly was talking about the Tarceva, and she was talking about issues with her physician when she tries to bring up maybe some things that she's learned here that she's bringing back to him or her as a question, i.e., should I have molecular testing? Can anybody maybe help Beverly with how to better speak with her physician about some of the things maybe that she's learning through this group or elsewhere that she's... Anybody?
Get it. And if your doctor won't give it to you, leave and go find somebody that will. It's that simple. You know, I was talking to somebody tonight. When a carpenter leaves their house in the morning to build a home, they go and they put a hammer and a screwdriver and a wrench and everything they need to build a home. And an oncologist needs all the same tools every day to do their job. And molecular testing is a giant tool that they need to be in their box. So you get the absolute right treatment at the right time for your disease, period.
Oh, Mike, Bev, sorry. That's going to take a while for us to...
Yes, I've been told by my doctor that there's necrosis now in any of the, and that it's all ashen, that there aren't any tissue to actually biopsy.
Well, you know what I would ask your doctor is, when you were first diagnosed, you must have had a bronchoscopy, correct?
Yes.
So that there is tissue there that was not necrotic because you weren't treated at the time, that hopefully is stored somewhere. Was your biopsy at a community hospital or a major institution?
Yes, and I was told that it wasn't a sufficient amount.
Okay.
So.
I think that they just didn't collect a sufficient amount, which was what happened to me. For 3 weeks, they just kept telling me, well, you know, these things take time. These things just take time. And I kept saying, said, well, how long does it take to get the genetic testing done? You're sending it out where? And finally they said, well, you know, we just didn't get enough viable tissue. We barely had enough to diagnose you. And at that point, I was almost 4 weeks into concurrent chemo and radiation. And I said, is there going to be viable tissue, or is it going to be radiated and, you know, chemicaled out? They said, we don't know. Nobody knew. And even though my first biopsy was done in almost a surgical suite by a radiologist using ultrasound-assisted something or other, you know, and it was a big, big deal. I asked him to take extra tissue. He did. There was still not, you know, there wasn't enough. It was like one day after radiation, a pathologist from the hospital walked in with a needle and said, I'm going to dig around and try to find some tissue. And he got plenty.
Okay, now also to that point, even if tissue is necrotic, they can still find some biomarkers in necrotic tissue. That's possible. Have you had tumors show up in other areas of your body that they could biopsy?
Just recently there was one, and I asked if another biopsy could be done on that, and they said it was too near the diaphragm, it was too dangerous to do that.
Okay.
You know, that bronchoscopy that we had to talk about, which is the kind that has little filaments that go way down.
Right. There's different equipment out there that can do different things, and there are some that can get to places that are, not able to detect
electromagnetic bronchoscopy
in certain areas. So we can give you some more information, and we will. I will have Danielle email it to you, where you can go back and ask your doctor, do you have super dimensions? Do you have this, that, and another thing? And if not, could you refer me to someone that does? Because I'd really, really like to get the biopsy. Now, work with your oncologist, because you might need the biopsy at a certain time, because if your chemo right now is working and you're doing well, you may not, he or she may not want to do something invasive on you right now, but you should still always have plan B. I highly recommend that everybody always knows what the next step is, even if you're not going to do the next step right now, that you know what's going to happen next. So we'll get you some answers on that to ask and say, well, do you have this, 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 and this? Because a standard bronchoscopy can't get to some areas that are difficult to get to, like out in the, pleura. So, does that make sense?
One other thing along those lines, and fortunately, ever since you were diagnosed and then I was diagnosed, there have been marked changes as far as chemotherapies, as far as approaches, even with biopsies. I have a scar this long, and that was only, 2009.
Right.
So, even since then, things have radically changed. Just to kind of give you maybe a modicum of solace, if my cancer were to come back, what we'll probably do is Dr. Gandara or one of his surgical partners, whatever you call them, will go in and take a new sample, a new biopsy. So unfortunately, I may, develop a new site, a new nodule or something like that. But they'll be able to go in at that point and get fresh tissue, because I am fortunate enough, because they took a whole lung lobe. There was plenty of tissue. So we're able to do genetic testing on some of the new treatments. The problem is with genetic testing is that if you go through several rounds of chemos, the tissue that you had originally really isn't totally representative of where you are now.
And your cancer changes.
And your cancer changes and mutates and all these sort of things. So it's almost like they almost need to get a new biopsy after a certain point, but that certainly is the call of your oncologist. So don't lose hope just because you haven't been able to get a sufficient tumor tissue at this point. If your treatment is working, as my oncologist said, for God's sake, don't change horses in the middle of the race.
Right.
Stick with it for as long as you can.
Exactly.
And then, you know, just keep riding it, because that's what I'm doing, is I'm hoping for the next treatment that'll take me as long as this one, hopefully. And it's just, unfortunately, you have to approach it like a chronic disease, because especially with something like bronchoalveolar carcinoma, it may take a while for it to come back, but they've had people get it come back in 8 to 10 years. So you need to be mindful, even though you are a complete response, you may not actually, and I hate to say this, but you may not be cured, but you may be stable and you're doing really well.
Right.
And it's really hard to deal with that, but have hope, because there really are amazing things that the doctors are doing these days, and you do have alternatives.
Yeah. Yes.
Okay, Carrie, TIAs.
Has anybody had experience with that? I don't know what it is.
So,
Transischemic
attack. So, you did prior to knowing you had cancer. So, I don't know that it really relates to what.
It's like a little mini stroke.
Sort of, yeah. You've had one?
So she had it during her.
Right. Were they saying it was a direct result of the treatment? Whoops.
You're
Way
fired.
to go, favorite
You're
uncle.
Yeah. Their best guess, but it wasn't conclusive. It wasn't a classic situation. No. And sort of how it all came about, but they did a brain MRI, that's what I got out of it, which was good, that didn't show any mets to the brain or anything else. So they were cautious, which I appreciated. But it was the oncologist that said at the next visit, you know, as a precaution, because you had this happen, we don't want to risk having it happen again or something similar. And so that's why they took me off of the Avastin.
So what I'm going to do, Carrie, is push that out for you to one of our docs, and I will get back to you with
Okay, great.
an answer.
Thank you.
Okay. And then Mary. So Mary was talking about how her last, and we were talking before the meeting started about her last scan. Somebody said there's something, somebody said it's been there, blah, 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 blah. So I thought you could maybe tell the story. But I think you might have been in Italy. Somebody just said, who just went to Italy? Somebody just say they went to Italy?
They're going to Italy. Becky's going to Italy.
Okay, Rebecca, that's right.
Rebecca's going to Italy.
So anyway, I think you were out of the country at the time, and I was supposed to go pick up scans, and I don't know what happened, but I had that panic attack, remember? And I'm calling you. Anyway, the story was that something showed up on a film, or they thought something had shown up on film, that when we went back to Fred Marcus, he was like, oh my God, who was reading this? We've been watching that for 3 years, and nothing has changed.
No, I was in Denver.
Were you in Denver?
I was in Denver. And that was when my sats went down to 50% and I ended up in the hospital.
And they did a CT at the hospital.
And they showed, and they're still watching it. It's a nodule that's like 2.4 centimeters on the right side.
Not centimeters, I don't think it's centimeters. Yeah. Anyway, it doesn't matter. I'm not going to correct you.
That's right, it's okay. Whatever. And, you know, it hasn't grown, but they watch it and, you know, they're looking to see, you know, if it turns out to be something.
Yeah.
And that actually is very, very, you know, happens very often, especially if you've had surgery, because when I have a CT scan, I've got staples and, you know, there's all this hardware in there and scar tissue and emphysema and, you know, God knows what else. You know, they really, you know, they have to get like 9 people to look at this to see if anything, you know, makes any sense. But that happens on a regular basis. So you know, I would always say, just say, well, you know, let me know when you think it's actually something, because right now I'm going to go on the premise that it's nothing, and let's just keep living our lives and living the dream. So that's what I think.
Okay, so that's all I picked up on. Did anybody else have anything that they were trying to ask and I didn't pick up on? And I'm assuming if you're sitting in the back, is he part of the Stahl family? I had a feeling. So I don't know if he wants to introduce himself or if he just wants to sit quietly. But there's another stall in the back of the room.
That's so cute. I love that.
So it is Preston. So Preston and I have emailed back and forth, as well as Penelope and I, for the last 3 or 4 weeks. And they've both been, and Hannah, I don't know that you and I have actually emailed back and forth. It's been primarily these two, but they've all been insanely involved in trying to get their mom where she needs to be, and they have. You should be very proud.
You should have been here.
Kind of awesome. Yeah.
You should have been here the night. And actually, everybody in this room that was here that night gave them their undivided attention and answered every question they had and sent them home with marching orders to tell you what you needed to do. And obviously they did, because look at you sitting there. Yeah.
Yeah.
Yeah. So, and EGFR positive.
Yeah.
Yeah. So, duh.
They told her originally stage 4 non-operable.
Yeah.
And they were just going to start throwing chemo at
Yeah. So now she's had surgery and she's EGFR positive.
Last month, her and I all of us were kind of a wreck and didn't know what to do. But it wasn't until we came here and started to get some ideas that we together all figured out where to go. And it's much better this month.
Yeah.
So on that note, and things being much better, I would like to ask Stephen, who's the president and COO of Alchemy, to come up and talk about some of the exciting things that are happening in, I say our world, because...
And just as a little primer before Stephen gets here, for the people that don't know what Alchemy is, you know, when we started the BJA Foundation, that was really because I was a very grateful patient. I had amazing care. I had David Joblins. I was told by Stanford I was inoperable. And David Joblins said, I'll operate. You know, it's risky, but if you're up for it, I am. So I had amazing care.
Yeah, please.
So I was a very grateful patient and started this foundation because of that. Was just going to have a little gala and a golf tournament, give the money all to UCSF. And then we started this thing, and it started to just get bigger and bigger, and it still wasn't enough. So we had a summit, and we invited the biggest and best thought leaders from around the world. We had a 2-day meeting in San Francisco, and we asked them if money were no object, what's the single thing you would do to make a difference in the survival rate of lung cancer? So unanimously, after 2 days of arguing, Harvey Bass, who was on our Alchemy board, he's a doctor at NYU, he stood up and he said, we need a biorepository of blood, tissue, and plasma, and we need to do collaborative research, and this needs to be governed by an honest broker that isn't involved in politics, red tape, or bullshit. And that's exactly what he said. So we said, okay, we'll do it. And so we started Alchemy. So we have a collaborative consortium of institutions across the United States and in Europe that also involves community hospitals, because in community hospitals, the tissue is discarded after pathology. It's not saved and it's not used for research, and this is gold. This is absolute gold. So we gave Alchemy a name, and we got together a group of these thought leaders that were in that room, and then we hired Stephen and told him, okay, go put it together. So that's Stephen.
Well, Bonnie just said everything I was going to say, so I have nothing. Alchemy is unique. Lung cancer is a very challenging disease. All of you are encountering as individuals. It's fractionated, a silo-based research. A lot of you came into this room through very disparate paths. And Dr. Gandera, apparently, I wasn't at this living room, but Dr. Gandera once famously answered, how many forms of lung cancer are there? And the answer was, as many of you are in the room. And of course, multiply that by tens of thousands of patients in the US and around the world. It's a very complicated disease. And to scientists' credit, they do want to collaborate. What they're missing is, to use Bonnie's analogy on the tools, they're missing a few things. And one of which is money access to driving this. We all know around the room that lung cancer is grossly underfunded. It's the invisible disease, the stigmatized disease. I don't accept the fact that there's a stigma that should be accepted to this, and I'm sure none of you do as well. The reality is all of us want to work together, patients and scientists. And rather uniquely, Alchemy was created to facilitate that. Alchemy is the only lung cancer research consortium that I'm aware of that was patient-founded, focused, and funded. And every project we take on has to have either immediate or very midterm to short-term patient benefit. And that is, quite honestly, not knocking scientists. That's a little bit of a different viewpoint. The output of scientists, and this is a good thing, is to put out papers and publish and advance the field of knowledge. However, sometimes the patients get lost in that mix. And so one of the things that we're most proud of on this consortium is Bonnie actually sits on our scientific board and can veto projects. We're not going to be hijacked by the old boys network doing Me Too studies or just doing studies for the sake of results. And to the point that came up before, some patients, quite honestly, end up on trials that are not likely to benefit them because they get sacrificed, if you will, and I don't mean that in a literal sense, sacrificed on the altar of statistics, of running projects, getting the data, publishing them, and yet sometimes, and too often, patients are lost in that mix. So to that end, Alchemy has established shared infrastructures. We help our scientists to collaborate. Every project we take on, as I said, has to have a patient benefit. And the other theme you've been hearing in this room is the importance of molecular testing. When we started our inaugural project called CASTLE 2 years ago, even 2 years ago, molecular testing was still only being done in the academic centers. Today, it's a little bit better. Even the community oncologists are using EGFR, but it's still not sufficient. On the other hand, if we understood this disease perfectly, we have to still have arrows, if you will, to shoot at this disease. And so Alchemy launched the CASTLE study to do two things. One was to lead by example, leading by example of incorporating molecular testing into a standard of care. And I think all of you agree there really isn't a standard of care, and I'm sure some clinician somewhere is out there yelling on the ether saying you're wrong. But I would hazard as a layperson to say that there really is no standard of care. So we established CASTLE to collect these tissues and specimens so that we can actually, on a going forth basis, really start to understand this rather intractable enemy called lung cancer. It is not a single disease. It's probably hundreds or maybe even thousands of variations on this. So one of the key raw materials, to use Bonnie's analogy, is access to tissues has been a major issue. The tissues are either necrotic or they're too limited in size, and it goes to a pathologist and he or she can tell you of adenocarcinoma or whatever, but there's not enough left over for molecular testing. So CASTLE is addressing that, and it is unique because we also are mandating or requiring serial biopsies. To the point that came up before, the tumors do change. And in fact, even when you start, the tumor is this mass. It's not a homogeneous mass of the same cells. It's really made up of a lot of them. So if you hit it with chemo, what you're doing is killing the cells that are sensitive to that chemo, but not necessarily killing all the cancer cells. So the future for all lung cancer, most cancers, is either a cocktail approach or a serial approach. And to that end, we've launched CASTLE, and we're working with a biotech, actually an international pharmaceutical company, to take these tissues and run them against about 150 gene panel for genes that are associated or thought to be associated with lung cancer. And that's done in a research environment. What's unique about Alchemy, I think, is we insisted that, fine, we will do this, but we do not want to make this an academic exercise. If a research result comes back that could have some impact on those patients that are donating their tissues, we will send that report in a research envelope, if you will, to the patient's physician so that he or she can order a diagnostic test to pursue on that. So that's really exciting. And by the way, we're getting this testing done for free. The patients get the molecular testing done for free that are in the CASTLE study. And this pharmaceutical company is running these samples against this panel for free as well. On top of that, to continue the free theme, and this is really the power of patient, we're also getting all our tissues stored for free by working with certain molecular testing laboratories, Response Genetics and Biodesics. So we're taking those tissues, running them against this panel. Results will come back. that's half the battle. The other half of the battle is to start developing therapeutics that will advance the field. So we're working in a collaboration with Clovis Oncology, who has a novel EGFR inhibitor that hits the T790 mutation, which, as those of you in the room probably know, is either an acquired resistance or something you're born with that can lead to a lack of responsiveness. So they're doing a clinical trial, and we're working with them to identify which patients, hopefully we'll identify patients that are more likely to respond to this drug and continue it on. And this EGFR inhibitor is an irreversible one, which is different, if you will, from erlotinib or Tarceva. We're hoping that will make a difference. Interestingly enough, the other aspect of this is it came up familial connections to lung cancer, inherited indicators of disease. And so we're working with a young whippersnapper for a doctor, if you will, at Dana-Farber, to do a national clinical study collecting specimens, spit, quite honestly, from patients that have been identified to have this particular T790 mutation and extend that into their families. So that in a way, it's a sort of an early detection thing, not only if the patient X, family member X has this disease, but it could also be an indicator for others in the families that have this, but either before, upstream or downstream, if you will, of you. This is early on. And finally, and I'll close here, one of the key aspects, if you will, of the metaphors is the lack of access to tissues and the silos of research. Well, a lot of those silos of research are also silos of data, if you will. Every investigator around the country and around the world have their own data sets, but they're not visible to each other. So continuing that theme of Alchemy being a patient-focused organization, we are setting ourselves up to become the data aggregator for all these disparate efforts. Put this data out into the public domain in either an analyzed or unanalytic format, so scientists around can not only collaborate, if you will, around a clinical trial, but also looking for patterns in this data that we're going to be capturing. Now, this all sounds great, and it is great. It takes a lot of money and a lot of effort, and it's a real credit to Bonnie and her family and supporters and the Bonnie J. Addario Foundation to take this on. And on a personal note, I just want to say that our director of the oncology nurse that works for Alchemy that handles our clinical operations sent me a text during this, and she said she's run and participated in hundreds of patient support groups, and she's never seen one or heard of one that's so kind, loving, and supportive as this one. And this is a testament to all of you, but also to the Bonnie J. Addario Foundation and Danielle, et cetera, and Bonnie to make this happen. So I'm just proud to be here.
Well,
Sally has something to say.
Okay. Can I answer that? Well, just some of the people in this room are in our trial and they don't even know it. Because UC Davis is a member of our consortium. UCSF is a member of our consortium. Alta Bates is a member of our consortium. Dana-Farber, NYU, Vanderbilt, et cetera, et cetera. El Camino will probably be very soon, so if you're seeing Shane Dormady. So we already are watching.
But I don't want people to be confused, especially people online, right, Stephen? So if you could explain about how that works.
Collecting spit is easy. You put it in a cup and mail it. Collecting a core biopsy, which is what we insist on for the for the Castle study, is obviously an invasive procedure. And speaking of which, I'm taking us off track for a second, but the hesitancy to collect core biopsies is not, in my opinion, is not at the patient level. A core biopsy meaning a bigger piece of tissue as opposed to a fine needle aspiration, which gets used up. And I would encourage all of you to talk about patient empowerment, demand that your tumors be characterized, those that are in the room and also on the live streaming, because it's ridiculous that these samples are not being collected. For the sort of relatively risk of collapsing a lung, it's generally not a fatal thing, whereas lung cancer can be, to make an understatement. So I would encourage you to demand not only molecular testing, but that your tissues be collected and be re-biopsied, because as we've heard, the tumor changes, it evolves in response.
So, Bonnie, why isn't Stanford?
Pardon me?
Why isn't Stanford?
Let's Stanford.
Just because we haven't gotten to them yet. Stanford, we're very close to Heather Wakely and the group down there, and they're now doing molecular testing on a regular basis, but when we started Alchemy, they weren't. But they are now, and that's all wonderful. And
The reason why
No, absolutely not. You know, when we started Alchemy, and Stephen can attest to this, our goal was to keep it small because we had to create and get signed contracts amongst all these institutions. We're the only contractual collaborative consortium. A lot of people say they share. You see Stand Up to Cancer on TV and they say collaborate, collaborate, collaborate. We're collaborating contractually. No one can be on this team unless they've signed on the dotted line. And they put the data into our system, and that's used for other people for their research. So it truly is collaborative. So because that took so long to do, you can imagine trying to get Dana-Farber, UCSF, UC Davis, Vanderbilt, NYU, Italy, France, and Spain to all agree to one contract is insanity. But we did, and it took over a year to do it.
We did, but if we could just step back for 5 seconds and go back to the original question was, how does patient X at Dr. Y get involved in Alchemy? And the answer is?
Bribe me? No, it's a process. It's a self-selection process. That's part of this. You asked the question, why did Stanford? And a lot of the investigators that are part of this joined because they are all convinced only by collaboration will they actually advance the field. And quite honestly, there are a lot of obstacles to joining a consortium like this. Status quo is one of them. Inertia, hesitancy from the attorneys, if you will, working for these hospitals. So it takes a lot of guts not only to establish a consortium like this, but also does as well to join it. And I'm sorry?
No, go ahead.
And on top of that, this is really, to me, it's driven by the patients and physicians. And no offense to any attorneys in the room or on the phone, we just roll past that and make it happen. And that's really what we try to do.
So I'm going to ask a patient question.
Okay, let me just throw something out there really quick. And don't misunderstand anything we're saying, and just because an entity that you're seeing, don't assume that they're not giving you the right care. What you really need to focus on tonight is the institution that you're dealing with giving you molecular testing? Right. Are you getting the option for targeted drugs? Are you getting personalized oncology? If you are, then everything is A-okay. We're not saying that Alchemy is doing something that no one else is doing. Each institution are doing these things on their own. They're not necessarily doing it in a collaborative, okay? So don't leave here thinking, oh my God, we have to go to one of these places in order to get good care.
And what my mom is saying, absolutely, and I wholeheartedly believe, first and foremost, as long as you're getting the care, it doesn't matter where you're getting it, whether it's an institution that's collaborating with Alchemy or not. But the question is, right now, as a patient, if I were diagnosed tomorrow with lung cancer, and my doctor was not part of the consortium, could I participate? Stephen, this is going directly to you, sorry. Could I participate in Castle? Could my tissue, if I were diagnosed tomorrow, so I'm gonna re-ask the question, and my treating physician was not part of the consortium, could my tissue be entered into the Castle study?
I'm sorry to say no, because we talked about this contract. Ownership of tissues and data is a very complicated field, not the least of which is protecting of patients. So the tissues that are collected under Castle under our consortium have to be governed by an agreement on how you can use these tissues and use of data. Patient protected. There is a lot of patient privacy protection laws out there. So I'm sorry, the short answer is no. On the good news, however, if one of the things we're trying to do is, yes, to keep the consortium lean and mean, if you will, so we're effective and we're not becoming a bureaucratic nightmare, is to set up feeler networks or referral networks to these core centers that are joining. And by the way, they're not all academic. In fact, to Bonnie's point, we really want to expand into the community. That's where the patients are. And Sequoia is hopefully under consideration to join us, and their expressed interest. So if you will, the samples can come in through many avenues. However, it's not as if you and I can just ship our tissues to this bank.
And that was what I was trying to get at, and why where it goes hand in hand with what my mom was saying is that although the answer to that is, like Stephen said, unfortunately no, the guidance that we are giving you regularly is the same things that the doctors within the Alchemy Consortium are giving to their patients. That's what we're telling you to go back to your own doctors and ask for.
And we, aside from everything we just said, we still partner with University of Colorado and all these other entities that are not part of Alchemy, but they are part of, they're all doing similar research and various different things. So it doesn't mean you're not getting, what you always need to be looking for is state-of-the-art care. You need to make sure you're getting molecular testing. You need to make sure that you're able to participate in state-of-the-art clinical trials and that these things are available to you from whoever is treating you. That's what you need to make sure.
Is your hand falling asleep yet, Sally?
Sally, go. Go, Sally, go.
Well, my question is, because I have a lot of lung cancer in my family, can I get this spit test to see if it is really a genetic thing, or is that only a group that's part of a trial now?
Well, first, the study will launch this summer. It's a very complicated study because it involves inherited genes, if you will, as opposed to what's called somatic genes, that when you get a transformation in the cells that are only specific to that, what you can't pass on to your children. It's complicated. But we will be starting this study this summer, and the patients that will qualify are patients that actually already have a confirmed EGFR T790 mutation, and the idea is to look into themselves and their families to see if whether it's considered germline inherited.
So it's only for people that have that mutation.
Right,
And mine was never tested, so I don't know.
For now, we're using this as a pilot. I mean, it's a very complicated endeavor, and we're using this as a pilot to sort of do a proof of concept on whether this could be expanded to
And
other.
once the concept is proved, then it will be very easy to get the T790 test.
Like the EFGR gene mutation plus something else?
There's another mutation called T790 that is either, it depends on your opinion, and I'm sure others in the room have a better opinion than I do. T790 is another mutation that can either arise with the EGFR EGFR mutation, or it predates it. And so when someone's on Tarceva and they're doing great, but 9 months, hopefully 12 years from now, they stop responding or start to stop responding, it's either because you've selected for those few cells in this ball, if you will, that have the T790 mutation that overcome. Basically, human cancer cells are wily little, I'm trying to not use a curse word, wily little beasts. And the whole point of life is to survive, and cancer cells, if you will, are selfish little guys and women, and their job is to survive. And the T790 mutation, again, I'm sure we can get a more scientific answer than I'm giving, but can overcome that. And so you're hearing that you should stay on Tarceva even if you start to stop to respond, because even those patients still do respond to a certain level. What we're hoping is this company, it's called Clovis Oncology, and others are working on such thing, have a novel EGFR inhibitor that will also overcome the T790 mutation.
But your takeaway from this whole discussion is that, Alchemy is we're doing our own clinical trials, and so are a lot of other people. This is not mutually exclusive, and we just want you to know that we are working for you on more than one level, but there are many levels, and we also know a whole lot about all the other trials that go on in the United States. I'm the lung cancer advocate for the SWOG, the Southwest Oncology Group, that just met last week, and every clinical trial that's going on in the United States happens through that group and another group called ECOG, which is the East Coast Oncology Group. So, there's a lot happening, and the good news is there's a lot happening, and it's a lot of good things that weren't even on the radar a year or two ago. So lung cancer is at a tipping point.
I just have a question from the audience. Sorry, I represent all the online 50 million people, or 29 tonight. Stephen, this is from R. Ronald Hare, and he is a board member and has been from day one. But he would like to know, how do the community hospitals get involved?
There are two ways in. One is they approach us and express interest, and Alicia and myself, Alicia is our oncology nurse that I mentioned, we go out and do a site visit and evaluate the institution and understand how many patients they have. And one of the aspects is, besides a motivated investigator or clinicians, is to find an institution with what I call a low bureaucracy quotient. How quickly can they get things done? One of the criticisms, rightfully so, of academia is it takes a long time for academic centers to get some things done. One of the beauties of community centers is that they don't have all that infrastructure and overhead and delay. On the other hand, they also don't have usually access to some liquid nitrogen tanks, et cetera. So it's a yin and the yang. So one is they self-identify, and secondly, patients can nominate it. We have a wonderful hospital. Right now we have 6 community hospitals joining Alchemy. All of them, well, 5 out of 6 volunteered themselves after hearing Alchemy presented at a conference. So to the questioner, so there's that aspect, and then there is also if we had time in the day, is actually proactively go out and find them. But to Bonnie's point, we want to keep this efficient. We don't want to replicate models out there that are slow and inefficient. We're just looking for like-minded institutions and grow slowly. And for example, we do have 3 institutions in Europe. We're not planning to add 20 institutions in Europe. Similarly, we're not looking for 20 more academic centers. We're looking more for the community centers that bring access to us, to the patients, and patients to us.
And we're looking for, in the community environment and the major institutions, a commitment to lung cancer, a real serious commitment to lung cancer.
I'm not sure if this is one of the things you addressed that I've been hearing about, which is biopsying for tissue that's not used for molecular, not used for the genetic markers for the targeted meds per se, but it's an assay that looks at what chemo drugs that are already in use would be best for each patient and which ones they should stay away from. I understand that the tissue has to be refrigerated and delivered immediately. It's not like, the tissue that was collected from me is preserved on slides in paraffin. It's not temperature sensitive, but I understand that these assays are temperature sensitive, time sensitive, and I'm wondering how prevalent this is, what this means for...
The assays are, on a good news front, are moving away from time sensitivity from preserving the samples. All these labs can work with what's paraffin-embedded tissues, so the normal pathology route. What's really, to me, interesting is they're heading into other forms, such as serum. Just take a little blood drop, which any patient could do a finger prick, put it on this card, mail it off, and that could be a prognostic indicator. So one of the laboratories we're working with is Biodesics, and they have a test called Veristrat that gives a binary yes-no answer to a patient that is EGFR. Are they likely or not likely to respond to Tarceva? That's just a small example of where things are going, moving away from big frozen core biopsies and the complications of handling to more simple approaches. And another approach that everybody's excited about, maybe it's still in the research realm, is capturing breath, somehow breathing into something and mailing this off. Again, the world's the oyster on all this. We're just early on, but validated commercial tests right now, what are called CLIA, done in a commercial setting with a diagnostic report come back. They can work with paraffin-embedded slides. They can take core biopsies. They can take serum samples.
I have a question. Is on? Hello? Yeah. I'm probably asking a question that's very, it probably might not make sense to anybody else because it doesn't make sense to me. But if I have a biopsy and they take the tissue, that's still my tissue, right? And they do their testing. Why can't I say, okay, you threw at my tissue, whatever's left I want sent here or sent there, so that tissue gets to...
And the short answer is it is your right to demand that your specimen to be sent for diagnostic purposes as you wish. Ownership is less the issue than control. The institutions control your tissue, just like Alchemy does when it comes to our tissue banks, but the ultimate controller is the patient that contributed. So you have the right to demand that your slides be sent off to any laboratory that you wish. But
you wouldn't want to send it here. to this office?
Yeah,
No.
Because we just have a little refrigerator in the kitchen.
No.
That wouldn't work.
No,
But you could send it to one of our institutions, and
That's what I'm
therefore it
talking
would
about.
be part.
As a means for you to get more tissue, the more people who know about, what's the name of the?
Alchemy.
Alchemy. The more people who know about it and know that you're doing this research and study, they say, listen, when you get through, I want my tissue, buddy.
I have a further explanation because I left an important part out. Yes, you can demand that your tissues be sent, but it still has to be ordered by a physician. So you'll find a like-minded oncologist. It could be anybody with an MD after their name, and they can order this to be sent out.
But I actually remember a patient, and this was a couple of years ago, who literally went to the hospital that had her tissue, was like, give it to me now, took it in her car
Right.
to another institution and was like, hi.
Right.
You know?
And we actually,
and that's exactly what she did. That's exactly what she did.
And we also had somebody that was, on the internet and found Alchemy and what have you.
This is
and
cute.
This is very cute. Actually knocked on our door and wanted
Here.
to know if they could
come in and get a biopsy.
Come in and get a biopsy. And it's like, we haven't, the dishwasher's not empty yet. We don't have our scalpels clean right now, to do this. But
so, Stephen, I think you might have already answered this question, but Kathy online wants to know where she can get her spit tested.
Well, first of all, we're developing, I think, a T-shirt called "I Give a Spit," but we're actually not there yet. So the study will be launching this summer. There will be a broad base, and actually, to that end, not only is it easy to ship spit, this doesn't require.
Say that 5 times really fast. Yeah. Ship spit.
I'll be careful how I say this, but. The idea behind the study is patients can actually send their own samples in. You don't need an MD to order a spit test. You can send it into this centralized laboratory that we're going to be working with.
But you have to fit a certain criteria.
Yes, there is inclusion criteria. There are specific criteria that you have to have a CAT scan available, et cetera. You have to have a confirmed T790 mutation, et cetera. But again, this is early on, so I don't want to over-raise hope. I mean, this is a research study. It's really to better understand the disease and the prevalence of this marker of the T790 mutation. Yes, it can help patients in the short term, but it's also part of a broader attempt to understand the disease better. Because as it comes back to Dr. Gandaro's comment, every one of you are different. And this is really just one of multiple efforts, to Bonnie's point. You should feel hopeful. There are a lot of people battling this disease. What we're trying to do in our small way, or our big way, is to help them work more effectively together.
And again, just to reiterate, there's a lot of major institutions out there that are doing amazing research. They really are. And we are also connected and partnering with them as well outside of Alchemy. So it's all a good thing. Our foundation gave out $1 million last year in research grants to University of Michigan, University of Colorado, for research that we felt they were, doing novel research that could affect the patients now. So, we're not limited to just one thing.
Jackie.
I was just going to say, Steve, I'm a part of your CASA study. My tumor block was at a hospital. They did my surgery. They removed my upper left lobe. It was there for 3-4 years. My oncologist requested. My tumor block was being held at a hospital that did my surgery with the upper left lobe. My oncologist that does research requested from that hospital the tumor block. Part of it went to Castle study. Some of it went to response genetics. Presently, another slice has gone off to do the FISH test right now. And then eventually it'll go back to the hospital, be held in my name. There's a number for it and everything. Yeah. And I wanted to ask a question in the room tonight about stem cell. I know of 2 friends recently on the East Coast that have liver cancer, and they've had stem cell treatments, and it's made a big difference. Does anyone know if they're using stem cell to help lung cancer patients?
Interestingly enough, do you want me to answer this? Yeah. So I had someone question me about that recently, so I did a little digging on it. And there are a couple of studies going on, but they aren't doing the stem cell research in lung cancer like they are, say, for paraplegics and quadriplegics and stuff like that, where they're trying for nerve damage and things like that. So yes, it's happening, but nothing's happening yet that's making.
And it's actually.
Oh, sorry. I'm sorry. My question was more along the lines of, is it because something like the liver or these other, nerves and things like that tend to regenerate versus something like a lung, and you can't really exactly grow alveoli or, lung tissue because it's so specialized versus something like, a liver can grow back or nerve tissue and that sort of thing. Is that why maybe stem cell isn't being used for these for this particular disease?
Well, first you have to know I'm not a scientist or a clinician. My understanding of stem cells' promise in lung cancer is more these little. It's really as a causative agent. The thought is when you're getting chemo, you're killing the fast-growing cells. When you're getting targeted therapies, it's killing the cells that have those particular markers. But somewhere, at one point in your life, one of your cells went wild, if you will. Cells gone wild. And the idea is there's a stem cell somewhere hiding out there that's not being hit by whatever chemo or whatever treatment you're getting, and that can, if you will, keep its head down low. So my understanding, and I'm not a scientist, is that that's what you want to do, is figure out a way to identify those stem cells so you're not only killing the fast-growing cells that are dividing, but also the cells that, if you will, led to that progeny. So you really want to identify what a stem cell is and, if you will, kill that cell so that you are getting the C word, the cure word. That's, again, my limited answer. I'm not a scientist.
Is that a Giants ticket?
Conference recently.
Is that a Giants ticket?
What?
Is that a Giants ticket?
It is a Giants ticket. That's why I wrote
just
her
checking.
name.
Is it for tonight's game?
Roselle Kurzrock from University of Texas. So MD Anderson is the head of their early therapeutics department in charge of phase 1 and 2 clinical trials. And she did a presentation, I heard, this is secondhand, of just that, about genomics, checking the genome as a way to identify stem cells. And she's, I think, the only person who's doing it with the sole purpose of lung cancer application. Did you happen to hear her presentation?
I don't know that there's just one person working on stem cells.
Yeah.
I know Zedong is working on stem cells.
Stem cell research is happening everywhere.
Lots of people are working on stem cells.
Just for lung cancer, though?
For lung cancer.
Yeah, okay.
But, nothing significant has arisen just yet. So
They're hard to find because they are us. The stem cells are us. So they're very hard to distinguish between the other cells. So it's very complicated.
Are you talking about it in terms of it being the cell that has mutated versus a stem cell that can transition from being like an embryonic stem cell that can turn into anything? Or I'm finding your use of the term stem cell a little confusing.
And that makes sense because I'm not a scientist. I pick this stuff off through osmosis. Bonnie likes to joke that I'm a scientist. I am not.
well, he talks like one all the time. So
which makes all of us crazy.
I can say proteomics and genomics and not necessarily know what they mean. Our job, if you will, as two foundations, is to drive progress and to support patients, et cetera.
And we work with a lot of scientists.
Right. So we would, when you asked that question, someone asked online said, "What's T790?" And my immediate reaction would have been to pick up the phone and ask someone because I don't know, or go to Wikipedia.
So, who?
What is that?
I don't know. Somebody tell who that. Oh, you have great earrings.
Oh, Bob likes your earrings.
She's got great earrings.
Bob likes your earrings. Look into the camera. Tell Bob thank you. Tell Bob thank you.
Say thanks.
Thank you, Bob.
So, you guys, I want to thank you all for your active participation tonight. I love the fact that we got to have one more round table before the new sort of kickoff to the official live stream begins, I hope it was as helpful for you all as it always is for me. A couple people on the phone or on the online, they're not on the phone. It's not, who's the guy that used to do the phone-a-thons? That's not what we're doing. Wanted me to say that we tonight are live from San Carlos, Dallas, Santa Cruz, Vancouver, Rancho Mirage, and Castro Valley. So those were the shout-outs that we got tonight with just the limited people that we...
But we did a soft launch tonight because we didn't want to do this with a guest speaker.
We
until
handpicked who we gave the URL to.
Because before we get a guest speaker in here, we wanted to iron out all of the...
Not that Stephen wasn't a brilliant guest speaker, because he was, yeah. So thank you all. It was an amazing night, and I can't wait.
Danielle, how can we get the word out about the live stream?
Okay, so all of you in the room, unless you just wrote down your email address, because it means I have yours wrong, or you haven't given it to me yet. I sent you in the reminder this month the URL to the live stream. The coolest thing about the way our amazing partners at Penn TV have put this together for us for the live stream is it's a click. It's one click. It's one URL. You don't have to sign in, sign up, create a password, do all that. You literally click on the link and it brings you into this room. So in your networking and the people that you may know with lung cancer, people who you know have family or friends with lung cancer, please pass it along, because I really feel like this is going to be an amazingly valuable tool to all the people, like I said, who can't be here in our living room with us, but can join us from their own. So.
Can they watch it at another time? Yeah. Like if they're not.
So yes, Sheila maybe knows how, because it's not. So we're still filming this, and it's still going. Our segments are still going to be pushed out into the 20-minute push-outs for the patient empowerment series.
It'll be up on video.
However, and you can see it on. If you're local, you'll be able to see it on Penn TV because they have so graciously. Sorry, Danny.
Channel 26.
Channel 26 here in the Bay Area. Where they will be for free pushing it out for us into the community on the peninsula. But in as far as if somebody in Santa Cruz or Dallas, is it Diane in Dallas that's on?
Diane's in Dallas and
Diane Jordan.
Alicia's upset.
Diane Jordan.
Oh, Alicia. Anyway, if somebody was in Dallas wanted to watch this whole thing, is there? Yes,
we're
they
going to
can.
video it and put it up.
We're going to have them all available.
It will be archived.
We're going to edit and put it up with our series.
And so the answer to that question for me right now is yes, and I will let you know how as soon as I know how. How's that?
All of you available for autographs and donations come to the foundation.
Yes. Yes.
But you can see, just in finality tonight, you can see that everything you all shared about your own personal experiences will be seen by other people diagnosed with lung cancer that don't have this resource.
And interestingly,
and
some comments
amazing.
coming through were, of all of the support group meetings, that I've been to, and all of my time in this area, in this field, or whatever, they've never seen anything quite like the group that we have here, and they're so happy to be a part of it. So that really encourages me and makes me happy that we're doing the right thing.
And I just want to make one more closing comment to all the wonderful people who helped us figure this out tonight. We apologize for the little gaps, the stalls. They will all be worked out. If it were not for you, we couldn't launch next May, but we're going to. We're bound and determined, and can we give those people a round of applause? They all wanted to give a lot of you hugs tonight, so it was an amazing experience, and let's take lung cancer down.
I didn't see any gaps or stalls. It looked like it was seamless. These guys made it
That
look
was one of
seamless.
the stalls are over there, yeah. That was one of the beautiful things for me tonight. Like, I know coming in, it might have felt a little intimidating. You see these cameras, and they're kind of big cameras, right? But for me anyway, as the night kind of progressed, you kind of forgot that they were there, and it was just us here. And everybody at home has the benefit. So don't get me wrong. There's people behind that door with some equipment that they came in with that they are able to put it.
They've been dragging stuff in here
Makes
all
no
week,
sense.
so
Yeah.
it's not this easy.
Yeah. Yeah. Yes. A huge thanks to Penn TV. Huge thanks to Penn TV. Yeah.
We can skip. We're going to get it right.
Yeah. So that's all. Oh, and the food's finally here for those of you who might have noticed that the food was a little light. There was an accident dump in the parking lot at the restaurant, and then there was a forget me on the salad. Anyway, please eat.
Did you notice when you came in there were like these two little...
I was like, what the hell is this?
Do I just stick a teaspoon in and take a bite?
Yeah.
What am I supposed to do here? Put it on a cracker?
Yes, and there's more wine. Yeah. So, thank you all.
Thank you all.